Hi, this is Junaid. We're going to discuss Acute Ischemic Stroke 2019 guidelines, the complete review of the guidelines in this series, starting with the first lecture, Purpose and Limitations of Guidelines. I'm really proud to present it with WeMed, which supported this series not just for them, but also for the whole community to bring to this important lecture series. Let's start with the conceptual framework. There are two opposing systems that we have to care for. One is the population health perspective, in which the patients at large in a group of individuals have a common disease, and we would like to have a common outcome and have a standardized way of caring for those patients. However, we do not want to forget personalized medicine, because every patient is an individual and has its own individual needs. So therefore, guidelines generally address both. Number one is how to deal with the population-based outcomes in terms of how to appropriately approach these patients in a systemic and standardized way, and also when the patient has an individualized needs, how to address that as well. So in terms of, let's say, stroke, which we're discussing today, is basically how do you approach acute ischemic stroke when the patient comes into the emergency room, and how do you approach that in terms of what to do this, and this. However, when patients has secondary stroke prevention, that would be separate, and that would be something personalized according to that patient's need. What is their bleeding risk, and how are we going to adjust antithrombotics in that individual patient? So again, from a conceptual perspective, population health and personalized medicine. What is the general guidelines purpose? The idea behind is that study after study have shown that when you actually do approach these patients in a systemized, standardized way, what you do is you improve effectiveness, you improve quality of care, you improve outcomes, you decrease the variance of clinical practice, and this actually, in general, also influences public health policy, the amount of dollars that needs to be appropriated for this kind of condition. So all in all, guidelines are extremely important. However, there are limitations for it. For example, there is lacking evidence. There is also evidence that is actually there but can be misinterpreted. The people who are writing guidelines are, at the end of the day, humans, and they have their own biases as well. So you have to keep all that in mind. The idea behind guidelines is not a legal decree, or it's not a commandment, or it didn't come from sky. It is a roadmap, and what you need to do is concentrate on the word guideline, and it is not a legal decree. So this is acute ischemic stroke, and which was also endorsed by AHA and also Neurocritical Care Society. And this was published in 2019, which was technically an update on 2018. But I'm grateful for Dr. Powers and all the other authors for their amazing work. So before we start on that, let's understand the difference between COR and LOE. So that's what you're going to use. I'm going to be using those words a lot throughout the lecture, so let's get familiar with it. COR stands for Class of Recommendation, that estimates the magnitude of certainty of the benefit. So for example, there are places where we don't really have the true level of evidence. For example, call 911. Can we have an evidence ever to say that this is actually level 1 evidence to call 911? It's impossible to get those studies done. But clearly the class of recommendation is very high. So in these situations, you have to understand the class of recommendation is what the authors have decided that it's extremely important or it is not that important. And then separately is the level of evidence. The level of evidence is actually looking at the clinical studies, RCT studies, case control studies, whatever there we have, what is the strength and the quality of that study. So with the level of evidence, you're looking at actual evidence, and then class of recommendation is authors deciding how important that recommendation is. So let's start with the class of recommendations. The number one is the level 1. Level 1 is the strongest recommendation, and they clearly come up and say it is recommended, it's indicated, it's useful, and the comparative treatment is actually beneficial, etc., etc. Then we come to class 2A, which is the moderate level of a class of evidence. The true strength is not that hard. It is reasonable to do. It is something you should consider highly, etc. And then we come to the other side, which is level 2B, level 3, and level 3, which is harmful. So again, the class of recommendation, if it's 2B, it may be beneficial, it may be considered, etc. And that's the wording they use. Again, the idea behind is that if you see a class of recommendation that is 2B, you have to be careful. You have to see if that particular level of evidence correlates with your individualized patients, and then decide if that class of recommendation actually works in your individual patient. The class 2, class 3 with no benefit, you shouldn't do, period. And class 3 produces harm, definitely avoid. There's no question about it. This is basically at that point in time, if you do that, either you're going to have a very strange situation. It can be done. I have done it before. And then you get proper consents and everything, and then there's proper documentation for it. However, in general, these are things that are not recommended. But there are times where you actually have to do that. And again, remembering that these are guidelines and these are not legal decree. Level of evidence correlates to the strength of evidence behind the recommendation. So for example, if you have level A evidence, it is actually either one high quality RCT, for example, Sampras or Warsef, but they did a beautiful clinical study that basically puts the question to end, and then, or there's high quality meta-analysis on high quality RCTs, and that is the highest form of quality of evidence that is available, and that's why it's called level A. Level B is moderate quality evidence, but clearly has multiple RCTs or meta-analysis of RCTs that are not as great, but at the end of the day, it does answer a few important questions. And then we come to even weaker evidence as we go along. Level B is, moderate quality evidence. It's not well designed, well executed RCT or registries, or, some of them studies that are actually not as good, or smaller studies when N is very small. All of these point to an evidence of, improvement or worsening, but they are not as good as far as the quality of evidence is concerned. Level C is purely non-randomized. As a matter of fact, some of these studies have not been done appropriately. And then level CEO is expert opinion. And these are things that are important, in my opinion, very important, because we know that there are people who have done some studies that because of the publication bias, it's a negative study and never got published. Or they have done the studies or in the middle of doing some studies, and therefore it is important that they include those sort of evidence within those guidelines, because guidelines can get updated at a slower pace as compared to the evidence that is coming, and some of the evidence is coming is slower pace as actual clinical studies that are conducted at the moment. So again, these are the important things that you have to understand. Class of recommendation and level of evidence. Class of recommendation points to the strength of the recommendation on the basis of the level of evidence. And the level of evidence is truly what the evidence is available and what is the quality of that evidence underneath the recommendation. Now, the whole guidelines is outlined into 6 major portions. We're going to review all of them in this whole series. Thank you very much for your time.
Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.